Welcome to This Week in Pediatrics. This week we are covering 10 notable papers spanning neonatal care and respiratory strategies, infectious disease interventions and long-term growth, and long-term neurodevelopmental and gastrointestinal outcomes in childhood. Let us dive in. We begin in the neonatal intensive care unit, where managing fragile infants requires balancing procedural risks with clinical efficacy. A major advancement in this space is addressed by a new international expert consensus, focusing on bedside transcatheter closure of patent ductus arteriosus in extremely low birth weight infants. Historically, definitive closure of a patent ductus arteriosus required either surgical ligation or transporting a highly vulnerable ventilator-dependent infant to a cardiac catheterization suite, which carries significant risks of clinical decompensation. This new framework establishes guidelines for performing transcatheter closure directly at the bedside within the neonatal intensive care unit. The consensus outlines patient eligibility criteria, pre-procedural planning, staffing requirements, and imaging protocols. By providing a stepwise implementation plan, the authors offer neonatologists and pediatric cardiologists a practical roadmap to establish a safe bedside program, ultimately mitigating the hazards of transport for these extremely low birth weight infants. Remaining in the neonatal intensive care unit, we look at how respiratory support choices impact physiological stability during therapeutic hypothermia for hypoxic ischemic encephalopathy. A retrospective multicenter study published in Acta Pediatrica analyzed data from 428 infants in the German hypothermia registry to evaluate the association between respiratory support strategies, carbon dioxide variability, and oxygen exposure. The investigators compared infants receiving continuous positive airway pressure, or CPAP, with those undergoing invasive mechanical ventilation. Nearly all infants in the cohort required respiratory support, with 88% receiving invasive ventilation. The study revealed that ventilated infants had significantly higher maximum partial pressures of carbon dioxide within the first 6 hours and over the 72-hour treatment period, as well as lower minimum carbon dioxide values, indicating greater carbon dioxide fluctuation. Furthermore, invasive ventilation was associated with higher inspired oxygen requirements and longer overall oxygen exposure. Conversely, in infants with moderate hypoxic ischemic encephalopathy, the use of CPAP was associated with shorter oxygen exposure, earlier oral feeding, and a reduced hospital stay. These findings suggest that CPAP is a feasible and potentially gentler strategy in selected neonates with moderate encephalopathy who exhibit favorable amplitude-integrated electroencephalography patterns, reminding us to minimize invasive ventilation when clinically safe. Predicting which neonates will require intervention is another key focus of early neonatal care, particularly regarding hyperbilirubinemia. Writing in Pediatric Research, researchers evaluated a non-invasive marker of bilirubin production, end-tidal carbon monoxide corrected for ambient carbon monoxide, measured using non-dispersive infrared spectroscopy. In a prospective observational study, the authors constructed age-specific percentile curves for end-tidal carbon monoxide during the first few days of life. They found that carbon monoxide levels show dynamic, age-specific changes, peaking in predictive value at 24 and 72 hours of life. Specifically, a 24-hour end-tidal carbon monoxide value above the 75th percentile was strongly and independently associated with an increased risk of subsequent phototherapy, achieving an area under the curve of 0.87. Rather than using a single, fixed cutoff, this study supports using age-specific percentile-based interpretations to improve early risk stratification and identify infants who need close monitoring for hyperbilirubinemia before discharge. To round out our discussion on high-risk neonatal care, we must address the systemic barriers that influence clinical outcomes. The American Academy of Pediatrics has released a new clinical report in Pediatrics focusing on social inequities in high-risk neonatal care delivery. This report highlights how structural racism, poverty, language barriers, nativity, and adverse social drivers of health intersect to produce disparate outcomes that can impact a child throughout their lifespan. The Academy urges pediatric healthcare professionals to recognize these multi-level inequities within their own neonatal intensive care units and implement targeted strategies to mitigate their effects, ensuring that clinical advancements are equitably distributed to all vulnerable newborns regardless of their background. Moving to our second theme, we examine infectious diseases and growth, starting with a major clinical trial addressing mortality in infants living with HIV. The empirical trial was a multi-center, open-label, randomized controlled superiority trial conducted across 19 hospitals in 6 African nations, including Côte d'Ivoire, Malawi, Mozambique, Uganda, Zambia, and Zimbabwe. The trial investigated whether empirical treatment with valganciclovir for cytomegalovirus could improve survival in infants aged 28 to 365 days, who were hospitalized with severe HIV-associated pneumonia. Participants were randomized to receive either standard of care, consisting of antibiotics and treatment for pneumocystis jirovecii, or standard of care combined with 15 days of oral valganciclovir empirical tuberculosis treatment, or both. Among the 558 infants analyzed, there was no statistically significant difference in all-cause mortality at day 15 or at 12 months between the valganciclovir and non-valganciclovir groups. Specifically, at day 15, 23% of the valganciclovir group died compared to 27% of the control group. At 12 months, mortality remained high, with 43% in the valganciclovir group and 48% in the non-valganciclovir group having died. However, when the investigators applied a time-varying effects model, they found that valganciclovir was associated with a 40% reduction in the hazard of death at day 15 and a 24% reduction in the hazard of death over 1 year when excluding early deaths occurring within 48 hours of treatment initiation. Importantly, valganciclovir did not increase severe adverse events, suggesting that empirical treatment may offer a survival benefit during the critical early phase of severe HIV-associated pneumonia, without adding significant risk of harm. The challenges of managing cytomegalovirus are not unique to infants with HIV. 11-year evaluation of hearing-targeted congenital cytomegalovirus screening. This study evaluated the impact of a Connecticut mandate requiring cytomegalovirus testing for all newborns who failed their newborn hearing screening. Analyzing nearly 200,000 births within a major health system, the researchers found that the mandate led to a 4.3-fold increase in annual diagnoses of congenital cytomegalovirus. Prior to the mandate, no diagnosed cases were asymptomatic, but after its implementation, 28% of diagnosed infants were asymptomatic or presented with isolated sensorineural hearing loss. Crucially, 75% of these infants later developed neurodevelopmental sequelae, and 81% of those with hearing loss at birth experienced a worsening of their hearing. These findings demonstrate that while hearing-targeted screening successfully identifies infants who would otherwise be missed, many infected infants still go undetected because they pass their initial hearing screen. This highlights the limitations of a targeted approach and supports the growing argument for universal newborn screening for congenital cytomegalovirus. We also must consider how in utero exposure to maternal infections impacts long-term development, even in the absence of transmission. The Drakenstein Child Health Study prospectively followed a longitudinal cohort of over 1,000 children in South Africa, up to 8 years of age, to evaluate the impact of in utero HIV exposure on postnatal growth. The study compared children who were HIV exposed but uninfected with those who were HIV unexposed. The researchers found that children who were HIV exposed but uninfected had lower overall weight for age and height for age Z-scores from 6 weeks to 8 years of age compared to their unexposed peers, with the most pronounced differences occurring before 6 months of age for weight and before 3 years of age for height. There were no significant differences in body mass index, Z-scores, stunting, or overweight. These findings highlight that even without contracting the virus, children exposed to HIV in utero experience early life growth deficits that persist into later childhood, emphasizing the need for targeted nutritional and developmental interventions for this growing global population. Our final theme explores long-term neurodevelopmental and systemic health outcomes, beginning with a reassuring large-scale study on obstetric interventions. A nationwide population-based cohort study in Sweden tracked over 630,000 singleton births to primiparous women to evaluate the long-term neurodevelopmental safety of vacuum-assisted delivery. The investigators compared neonatal and long-term outcomes of vacuum-assisted delivery, stratified by fetal head station, using emergency cesarean delivery and spontaneous vaginal delivery as reference groups. The median follow-up was 13 to 14 years. The study found that while mid or low vacuum-assisted delivery was associated with significantly higher odds of neonatal complications, including a 7-fold increase in traumatic intracranial hemorrhage, a 3-fold increase in non-traumatic hemorrhage and subgaleal hematoma, and nearly doubled odds of neonatal seizures, there was no increased risk of long-term neurodevelopmental disorders. Specifically, rates of attention deficit hyperactivity disorder, autism spectrum disorder, cerebral palsy, and epilepsy were not elevated compared to emergency cesarean delivery, and there was a 20% reduction in the risk of intellectual disability. Outlet vacuum-assisted delivery performed similarly to spontaneous vaginal delivery, showing lower risks of both neonatal and long-term complications. While the clinical circumstances driving the choice of delivery mode must always be considered, these findings provide strong reassurance to pediatricians and families that vacuum-assisted delivery does not elevate the risk of long-term neurodevelopmental impairment when performed appropriately. Next, we address a common complication of pediatric pancreatic disease. A study from the International INSPIRE-2 Consortium. The researchers found that exocrine pancreatic insufficiency was diagnosed in nearly 20% of these children, and the cumulative incidence reached 24% at 7 years after the first episode of pancreatitis. Fecal elastase, which was the most common diagnostic tool used, demonstrated a high negative predictive value of 92% at a cutoff of 100 micrograms per gram, and 93% at a cutoff of 200 micrograms per gram. However, its sensitivity was modest, ranging from 56 to 65% depending on the cutoff used. The study also revealed that children with genetic risk factors progressed to exocrine pancreatic insufficiency significantly faster, with a 56% increase in the hazard rate. These results suggest that while fecal elastase is highly effective at ruling out pancreatic insufficiency, its low sensitivity means it cannot be relied upon alone to rule it in, and children with genetic predispositions require much closer clinical monitoring. Finally, we turn to a common and frustrating outpatient challenge: refractory monosymptomatic nocturnal enuresis. A scoping review published in the European Journal of Pediatrics evaluated second- and third-line treatment options for children who failed conventional first-line therapies. After screening over 2,500 articles, the authors identified 17 eligible studies comprising over 1,300 patients. They found that combining first-line therapies with treatments such as biofeedback, electrical nerve stimulation, anticholinergics like oxybutynin, beta-3 adrenoceptor agonists, tricyclic antidepressants, or selective serotonin reuptake inhibitors improved complete and partial response rates. However, due to highly heterogeneous study designs, small sample sizes, and a lack of unbiased prospective randomized controlled trials, the current evidence is insufficient to support a standardized treatment algorithm. Pediatricians must continue to individualize therapy for refractory bedwetting, recognizing that while various combinations can be effective, high-quality clinical trials with long-term follow-up are still urgently needed. If you only have time for one paper this week, make it the nationwide cohort study from Sweden on the long-term neurodevelopmental safety of vacuum-assisted delivery. This landmark study provides robust long-term reassurance to pediatricians counseling families about delivery-related trauma, demonstrating that despite transient neonatal risks, vacuum-assisted delivery does not increase the risk of long-term neurodevelopmental disorders compared to emergency cesarean section. Here are the key takeaways from this week in pediatrics. First, when managing extremely low birth weight infants with a patent ductus arteriosus, consider establishing a bedside transcatheter closure program to avoid the high risks associated with transporting these fragile neonates. Second, during therapeutic hypothermia for moderate hypoxic ischemic encephalopathy, continuous positive airway pressure is a feasible alternative to invasive ventilation that is associated with less carbon dioxide variability, reduced oxygen exposure, and shorter hospital stays. Third, while hearing-targeted newborn screening for congenital cytomegalovirus significantly increases diagnosis rates, many cases are still missed, and a high proportion of those identified will develop progressive hearing loss or neurodevelopmental sequelae, highlighting the need to advocate for universal screening. Fourth, in children with acute recurrent or chronic pancreatitis, fecal elastase is an excellent tool to rule out exocrine pancreatic insufficiency due to its high negative predictive value, but its low sensitivity means a normal result should be interpreted cautiously, particularly in children with genetic risk factors who progress to insufficiency much faster. That's your roundup for this week in pediatrics. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.